Next, we will have the Sickle Cell Society UK Cure, a patient advocacy perspective. In absence of Mr. John James, Ms. Michelle Salter will discuss this. Good morning, Ms. Salter.
Good morning, and thank you for inviting the Sickle Cell Society. I'm the Vice Chair and Treasurer of the Society, and it's a pleasure to step in for John. There was a little hiccup on the diary. Thank you for sharing the slides. So I'll go through. There are many charities which represent the patients or warriors, sicklers in the UK. But the Sickle Cell Society are the only national charity, so we cover England, Scotland and Wales. Next slide, please. That's part of our team. Very excited. John James in the blue shirt, our chair, Kai Bangola in the wheelchair, myself and the fellow trustee, Carol stood next to me. And we're have just been awarded the GSK King's Fund Impact Award, a very prestigious award, recognising the impact that we've had as a small-sized charity on our community. Next slide, please. So we were set up in basically 1979, just over 41 years ago, by a group of patients, parents and health professionals, because of the lack of understanding in advocacy of treating sickle cell disorder. Our mission then and still remains to enable and assist individuals to realise their full economic and social potential, and really looking to improve the opportunities of individuals and their families that are affected. By raising public awareness, this is primarily through education, of course advocacy, and provision of direct welfare services. And although we don't conduct research ourselves directly, obviously assisting in that process, and one of our health partners being Novartis, to work with Pfizer, Terumo, and lobbying. So lobbying really our government. We perform the secretariat for what's called the All-Party Parliamentary Group for Sickle Cell and Thalassemia. If we can have the next slide, please. And really, we're still in COVID, and this slide demonstrates that it's affected everybody for all walks of life, all ages, a global condition, and disproportionately it's affected Black and brown people, people from ethnic minority backgrounds, and has had a change in impact in terms of life, in particular for individuals who have sickle cell disease, and were part of what the UK had was a shielding process for the extremely clinical vulnerable. As a charity, we couldn't close, our doors remained opened, and we continue to support the community, and particularly around areas such as advice around vaccines. So we ensured that we had expert medical advisors. So it just wasn't, the views of ourselves, but taking, the best scientific advice out there, and strongly encouraging those with sickle cell to get the vaccines. Next slide, please. So hemoglobinopathy and COVID-19. So quite encouragingly, in some respects, we did not see a significant impact or a disproportionate impact in terms of deaths for individuals with a sickle cell. What we can't discard is to what degree that is because individuals did shield. So they, taking that advice, was not exposed to the same level of those who may have well continued in public facing roles or in office environments, factory environments, working with colleagues. And again, that early intervention in terms of vaccine uptake. And our government, and now we've had the first doses, second dosage, And now our government is recommending that there is a third booster dose for those people in the vulnerable clinical categories, which would in turn include sickle cell. Next slide, please. So we've done lots of talking with our groups, our community, to look at assessing the benefits and risk of harm of cure versus disease modification treatments when we're talking about long-term cures. What choices are available? I mean, you know, it's very much a limiting factor. Initially, for a long time, until just recently, it was only sibling donors which were accepted for adults and children, and this has now been broadened. But absolutely, we're really keen to learn about the long-term effects, you know, what the evidence is, and hearing from Galer and others, it's really important. Chantel just mentioned about the psychological impacts, and these are all things that obviously we can't ignore. You know, it's not just oh great, you know, we have a cure. Obviously the various cures that are currently available have their own risk, but also it's looking at the individual as a whole. And again, it's quite confusing. I mean, the feedback that we've got from individuals is not really understanding the language of genomics. So we're really asking, and for any medics that are listening today, it needs to be translated into, you know, we're saying plain English, but obviously the language applicable to the patient group, it's got to be fully understood, the risks and potential benefits by the patients, and medical speak isn't always helpful. Next slide, please. So clinical preferences. Transplanters want to transplant. Physicians don't always share the same clinical point of view. So again, we've got confusions there that depending on who the medic is, they're pushing what they're familiar with, their experiences, their knowledge from colleagues. And really what we're looking at is a much broader approach. So we're calling it a tripartite discussion, absolutely with the patients at the centre of it, patient engagement, but also we should be talking about patient-led as well, once they have the appropriate information. And of course with both the transplanter and physician, in terms of, again, weighing up the implications of what road they go down. And again, you know, we're crying out for more understanding around clinical outcomes analysis. Next slide, please. So again, lots of money signs on this diagram, because we can't get away from the fact that money plays a role. So absolutely patient's choice should be continuing to be a key factor, but also financially, some options may be just taken away from being a realistic choice option, at least initially, until the prices to treatments come down. And again, you know, this is a global discussion, and there are different funding models depending on where you are in the world. So for ourselves here in the UK, we have the National Health Service, which means that care is free at the point of delivery, but that doesn't mean to say it's free care. It's funded through a taxpayer system. So taxes going to the Treasury, to the Department of Health, and then are filtered down into treatment centres. And particularly around new innovations, when they come to market, we need to, new medicines not only need to be deemed to be safe and ethical, But in terms of affordability, they go through what's called NICE, the National Institute of Clinical and Health Excellence, where they do their cost benefit analysis, and clearly arguments need to be argued around not just the cost of the intervention, but actually what does that mean in terms of if an individual like Galer we just heard from is no longer having to access healthcare services on a regular basis, that you don't have individuals presenting at A&E, may have to be admitted for a long time, may have to have very intense intervention in terms of keeping them alive. And earlier on we were talking about risk of heart attack, strokes, negative impact on pain, individuals needing hip replacements, etc. So we've really, when cost benefit analysis takes place, whatever country this may be in, the broader picture needs to be taken into account to actually say it's not just the cost of treatment, it needs to be weighed up in terms of the whole cost of that individual being cured. Next slide, please. So sickle cell innovation landscape. So we're very encouraged that there are new drug and gene therapy innovations in the pipeline. I've talked about the National Health Service and the National Institute of Clinical Excellence. So there are hurdles that in the UK we need to contend with. It's not just enough that the pharmaceutical companies have come up with these solutions, and absolutely around cost and affordability around these disease modifying drugs versus the curative cost. Next, please. So the key message is back to clinical consistency. It's really not helpful if patients are being given conflicting advice reflecting that particular clinician's, as I said, experiences. Safety and efficacy absolutely has to be number one. And I think, again, I'm sure it's not a phenomenon just unique to the UK, but if we take the vaccines against COVID, again, there's lots of concerns around its safety and efficacy because of mixed messages which have come out. So individuals really need to be assured that it's appropriate and the best thing for them to do. Got to speak to us in clear English with full explanations, and our concerns listened to and responded to constructively and with clarity. We need to understand the clarity of those outcomes and the risk against the benefits. It has to be evidence-based. And absolutely essential is the involvement and engagement of patients. And I would go back to, we've talked about patient-centred, patient engagement. We now need to change the language to being patient-led. Next slide, please. And if you want to contact us, that's who we are. Thank you very much.
Thank you, Ms. Salter. Can you talk a little about any concerns after transplant that you all may be experiencing or that you foresee?
I think it goes back to the statement that Chantal had made around, again, the psychological impact. So we do need to be ensuring that we're looking at the whole person and not make an assumption that, it's taken place, you should be fine now. And again, it's continuing with that evidence building. The numbers are still relatively small, so there shouldn't be assumptions made about the outcomes for those that have gone ahead are necessarily going to be the ongoing outcomes. So continue to do that evidence collection and feeding back. So the more that we hear from those individuals who have benefited, that's part of the education process for individuals to go forward and make their own decisions as to whether that treatment is right for them or not.